Okay. Welcome everybody to our Soteria Research Project question and answers. Um, the Soteria Approach as a radical alternative to inpatient care. We've got the panelists. My name is Eamon Flynn. I'm a trustee of the UK network, amongst other things. Can everybody introduce themselves? Jen, you're on my screen first.
Hello, everybody. Good to see you all. Yes, so my name's Jen Killian, and I'm the acting chair of the Soteria Network, and I'll be saying a little bit about the network soon.
Rita, you're next.
And
Hi, everybody.
Rita, yeah.
Absolutely delighted to be here. I'm Rita, and I'm a friend of Soteria's, been working alongside Soteria for a number of years. And I'm also the co-lead of the project with some very fancy titles. Sometimes I'm called a community researcher, a person with lived experience. So yeah, that's me.
Adam, can you say hello? You're our super tech guy. Thank you
Hello.
for your support.
I'm just here to make sure things go well.
Thank you. Kate, can you introduce yourself?
Hi everyone, my name's Kate Allsopp. I'm a research fellow based in a research unit called the Complex Trauma and Resilience Research Unit at Greater Manchester Mental Health NHS Trust. So good to see you all. Looking forward to today.
It might be worth knowing, Kate, you're co-leading the project.
Thank you. Nick, you're on the screen next.
Hello, everybody. I also work at the Complex Trauma.
I think
you're on mute, Nick.
Nick's
I think she's
mic
on
is
mute.
off, or she's frozen.
Hello, can you hear me now?
Yeah. Start again, Nick.
Apologies, guys. Sorry. My name's Nick. I also work at the Complex Trauma and Resilience Unit, and I'm a research assistant on this project.
Thank you very much. And John, can you introduce yourself?
Hi, I'm John Reid. I'm Professor of Clinical Psychology at the University of East London, amongst other things. Most of my research has been around the psychosocial causes of psychosis, but more importantly, I've been a big fan of Soteria for over 50 years, and not many of you can say that.
That's impressive, John. Thank you. Okay, so I think we'll get going. Just going to say a few things. Just for me personally, my son has been in so many inpatient wards. This project is so personal to me, and I'm so proud of my trustees and former trustees and Rita for getting this research across the line to an amazing research team at the Greater Manchester Health Trust. So thank you everybody for just getting us here, and this is the start of research, and we are a small team at Soteria Network. We are always on the lookout for volunteers. At the moment, we want to build our capacity. We've sent on an email a link to if any trustees, volunteers. We're looking for a secretary and strategically for a chair. So we're looking to build our capacity over the next short future. But that's it. I think we're going to go straight in. We've got an hour. We're going to just briefly what we're going to do. John's going to give a brief history for 5 minutes. Jen's going to talk about Soteria UK network. And then Rita is going to talk about why research. Then we're going to have our first questions. So again, everybody, please use the Q&A box. And we've got 4 in the box already, so great. So keep them coming. Any questions will be really helpful. We just want to get a sense of what you think is going to be looking at too. We're going to have our first questions at 7:30 for 5 minutes. And then Kate and Nick are going to do what we're doing next on the research for 15 minutes. And we've got 10 minutes at the end for a final roundup. So that's what we're going to do today. And we'll be closing at 12. It's a nice short webinar. So I guess, John, if you're ready to go, 5 minutes on the the history of Soteria.
Okay, 5 minutes on Soteria. There's a challenge.
Yeah.
I could talk for half an hour or more about Lauren Mosier, because there's always a champion to these things, although it was a team effort, but he clearly led it. And he was a radical American psychiatrist in the 60s, 70s, and 80s. And it's important that it was led by a psychiatrist, I think. Soteria House opened in 1971 in California. It was followed in 1974 by a second house. There were houses in the community. Second house was called Emanon, and they lasted until 1983. And in Lauren's own words, they closed despite or possibly because of how effective they were. We'll come back to that. So to stop me going off at all sorts of tangents, I'm going to read some of Lauren's words, his attempt to pull it all together. Soteria rejected the doing to connotation of treatment and did not accept the disease model of schizophrenia. At its core was the idea that psychosis should be dealt with directly, face to face, without the external impediments of theory, artificial institutions, professionally acquired belief systems and practices, and without the chemically induced changes in awareness from antipsychotic drugs. It focuses on finding shared meaning and understanding of the subjective experience of the person. Soteria eschewed the medical model. Its facility was a home in the community. It utilized non-professional staff trained to relate to and understand madness without preconceptions, labels, categories, judgments, or the need to do anything to change, control, suppress, or invalidate the experience. Very good with words, Lauren, because it crams a lot into a few sentences. Just to stress, though, its most basic tenet is being with. An attentive but non-intrusive, gradual way of getting oneself into the other person's shoes, so that a shared meaningfulness of the subjective aspects of the psychotic experience can be established within a confiding relationship. So those are Lauren's words himself, from his description himself. What some people don't know is that apart from being a wonderful human being and helper, some people are natural helpers, and he certainly had that in spades. He was also a prolific researcher, and Soteria House, this is important in efforts to get things off the ground, as you all know. It was well researched. A 1-minute summary of that. After 6 weeks, and it's a properly designed randomized study where half the people were randomized into the normal care as usual, an inpatient unit, and half into Soteria. And after 6 weeks, they were equally effective at symptom reduction, which actually surprised Lauren, because that wasn't what he was aiming for. He wasn't particularly concerned whether people kept hearing voices or not. He was concerned about their quality of life, with or without voices. So they were a bit surprised by that. More importantly, though, at 2 years, they had actually better outcomes, however you measured it, whether it's symptom outcome, quality of life, percentage of people who got back to work. And in some ways, the most fascinating finding was that 43% of the people never were on antipsychotics, and that group had the best outcomes of all. So in a nutshell, to conclude, Lauren didn't think that it was a good idea to collect the 100 most distressed people in a community and put them in the same building. And we're still doing that today. It ended in 1983, as I say, and I think it was because of how effective it was. Lauren came back from holiday one day, and his desk at the NIMH, the National Institute for Mental Health, where he was the research director for schizophrenia, his desk had been cleared. And he believed to his dying day, and I was fortunate enough to know him towards the end of his life, he was convinced that was because Soteria House was such a threat to the powers that be. So that's my attempt to summarize a wonderful, wonderful project in 5 minutes. And over to Jen for slightly more recent events. You're on mute, Jen.
Thank you so much, John. What a wonderful start to our evening. So in 2004, after Lauren Mosher had and Voice Hendricks had published this book, he went on a speaking tour around Europe, and he came to the UK, and he came to Bradford, where I live. And that's where the Soteria Network was first formed. So we're just over 20 years old. Unfortunately, I didn't meet Lauren, but I heard a lot about him, and I heard what an inspirational guy he was. So I joined the network, I think, in 2005. And I've been part of it ever since in different ways. And I was drawn to it because, like Eamon, I have a son who's been in and out of psychiatric units and didn't find them helpful. And I wanted to see change. And I was very impatient, and things didn't happen straight away, but I stayed with the network and helped organise conferences and helped for information to be sent around so that more people heard about it, liaised with groups I knew, spread the word, got more people involved. And then just before the webinar, became the chair because it was vacant and I didn't want to see the organisation fold. During the webinar, during the pandemic, we put on lots of webinars, and I think that was where we spread the word more. But we, all the way through, we still spread the word about why Soteria was important, why Soteria houses and a Soteria approach was working, and stuck to the core principles that John has described, not non-coercive, no medication or very low medication, informed choice, being with, not doing to, and about psychosis having meaning, and being with someone and being in the present, and not coming with your own ideas of what somebody needed, not preconceived ideas, and not having a plan to fix somebody, about spending time with that person, helping that person to understand what might be happening. Along the way, I met Rita and Eamon, and if it hadn't been for Rita, I don't think this research would have begun. I think it was her and Eamon's tenacity, commitment, determination to show. We all knew that we needed Soteria, but we agreed that the best way of getting funding to set up Soteria houses was to have research that was seen in this country as effective. And so Eamon and I worked alongside Kate and Rita to set up the research. So right from the start, we were there ensuring that it was community-led and community-informed, and I'm proud to say that it's stuck to that. And also through our international connections with ISPS and other organisations, we've been able to learn from what's happening around the world, and there are Soteria houses around the world, and I think it's important we all learn from each other. Just reminding you what Eamon said at the beginning, we are looking for a new chair and under secretary, so please go to our website and look on the top right hand side where it says join us, and we'd be great to hear from you or from anyone that's interested in being part of us. So thanks very much. My 5 minutes has just gone. And if you've got any more questions, you can put them in the Q&A and we can follow them up. And now over to Rita, who's going to tell us why research is important.
Oh, thanks, Jen. Thanks so much for that introduction. Yeah, so as Jen says, what I want to do now in this quick little spot that I've got is to sort of give you guys an idea of how we've got to this stage of research. So how we got here and why we're doing it. And when you think about it, as John said at the beginning, Moshe did his research in 1971. And we're sat here now in 2025, really at the very beginnings of official research. There has been some research done between now and then, but not in the way that we would want it in the UK to be evidence-based and etc. for the NHS. So what happened was, as I say, you know, I'm a friend of Soteria. We had lots and lots of conversations over the years about how are we going to set up a house. You know, we've got all sorts of ideas. Someone will give us funding. Somebody will win the lottery. All sorts of things will go on. And then one day we had this realization that in the UK, if we're going to get Soteria houses that are equitable so that everybody can access them and sustainable, so we're not going to run out of money, we need to work with the system that we've got. And I'm sure you guys that are here that know about Soteria, that was quite a conflicting conversation to have, because Soteria is described by some people as a very radical approach. I think it's really simple, but to be fair, in the UK, it is seen as something quite radical because it really flies in the face of the medical model. It's not anti-medical model, it's just different. So what happened was, Soteria in itself, the reason it was set up, Soteria Network UK, is we knew that we wanted something different. We knew for some people, for lots of people, the medical model wasn't working. That people are going into hospital and sometimes getting worse, getting traumatized. So we knew that. But there was a growing body of people, nationally and internationally, including the World Health Organization, that were saying we actually need something different. So we were sort of like on this cusp of a wave where we could see things were starting to change. And at that time, the National Institute of Health Research, the people that institute research, did something that's called a community call. So what they mean by that is they wanted communities to come up with their research ideas. Because as we know, often academics and clinicians come up with ideas and they will discuss it with communities. It's not done in isolation, or at least shouldn't be. What they wanted to do is really turn it on its head. And they wanted people like us, Soteria Network, to actually come up with ideas, and they would match us with clinicians. So we thought, should we give this a go? This is the time to pounce. Very luckily, we already had contacts with John and the complex research unit where Kate and Nick work, and that was really important to us, because we knew that there were going to be some very, very tricky conversations, and in anything that's properly co-produced, there will be tricky conversations. And Soteria in particular, that's very different from what is offered at the moment, could be even more tricky. So what we did is we started having conversations with CTRU, the Complex Trauma Research Unit, with the trustees. The trustees said, look, this is really important to us. Can we actually meet you face to face? We need to see you and look you in the eye. And we did that. That was organised by Kate's team. And we had a meeting in Manchester. And that really was the start of, really the basics of, I think we can work together. I think we trust each other enough. We know each other's values. We're going to put this together. So we actually put in a grant, which is for a year. It's called a Programme Development Grant. And that the idea of the Programme Development Grant is you get all the information that you need to actually go on to the next stage. So that's what we're doing now. And Kate and Nick will tell you more about that in a bit. So, I think what I would say about it is when you're doing anything that's co-produced, it can be a very rocky, difficult set of conversations, but that's really important. And you've got to have a really good team that can trust each other and be open and honest. And I can honestly say, because of the grant that we put in, that we developed that, and it's, credit to all sides. And just before I pass over to Nick and Kate, who will tell you more about exactly what we're doing in this year, I thought it was interesting once when we were at a conference and somebody said to Kate, me and Nick, and went, isn't it great you've got academics and you've got Soteria and you're all working together and it just fits? And I said, actually, we're working together, but it actually bloody doesn't fit. It's because Soteria does not fit exactly into the models that people are used to. And that's the exciting but challenging part of what we're doing. So we really appreciate that you're a part of this journey. So over to you two guys.
Thanks, Rita, and thanks everyone for a really helpful introduction to the research. Eamon, could you share our slides, please?
I'm going to ask Adam too, please.
Oh, thanks, Adam.
I don't have the slides, Eamon.
Oh, beg your pardon. I'll put it up then. Can you see that then?
Yes.
Okay. Do you want me to scroll down for you as well?
Yeah. Are you able to put it onto full screen mode in the bottom right, next to the slider? There should be one next to the minus button. Then that should be full screen.
Bear with me.
On the very bottom of the window on the right-hand side.
Which
Don't
window,
worry.
sorry?
So on the PowerPoint screen, if
Okay.
you go right down to the bottom on the right-hand side,
Oh,
next
yeah,
to the
okay.
left of the minus button, if you hit that, it should go full screen.
Left of the what button?
See the little slider? Yeah, to keep going right.
Okay.
And then, so keep that. You can keep the slider, but to the left of that, left of the slider, there's a button that's looks like a little screen on a stand, just where you were before.
There's
Don't
a
worry.
button. Fit slide to current window, yeah?
That might work. Give it a bash. No, it wasn't that. Don't worry.
Eamon, I've requested to control your screen.
I
just
think
see
I've
if this
confirmed.
is working.
Oh, there you go.
Yeah.
Amazing, thank you. If we could skip forward to slide 6, should be our research. That's brilliant, thank you. Brill. So yes, so Rita has given a bit of context in terms of the how the research grant and the study came about. So Rita and I are co-leading the research together and equally. And what we've got on the research team, I'll just take you through the other members of the team. So we've got Filippo Veresi and Catherine Berry, who are both professors of clinical psychology. We've got Gemma Shields, who is a health economist. We've got Paul French, who's a clinical academic and a psychiatric nurse by background. And then Steve Wright, who's a consultant psychiatrist. And actually, we've got some notable omissions on this slide. We've also got Nick Warrener, who's with us today. So she's our fantastic research assistant for the study. And really importantly, we also have a community research team as well. And that team is a small group of really fantastic people who all have their own lived experience in different ways that's related to this research. And we are co-producing our research with them. So we've been meeting for sort of several whole days at a time, really thinking about our research. So they're helping to co-design what we're doing. They're helping us to ask the right questions, think through from lots of really different perspectives, different from ours, and kind of helping us to think through and guide our research. And they'll be helping us to co-analyze our data together, so that we've got that lived experience perspective embedded throughout our research. That's really, really important part of it.
It's 8 o'clock.
And what we've got is so we've got 12 months to do this research. So in research grant terms, that's actually a really small amount of time. We started in January, so we're coming up to halfway through. And really, it's a year to be doing lots of exploratory work, to be doing exactly as Rita said, so to be really thinking about how might Soteria fit within a UK context, and what might that look like. So if we go on to the next slide, please, Adam. So the different aims of the study are to, so first to understand, is there an appetite for an approach like Soteria within the UK? Do people with lived experience and their family members want something like this to be available? And what about professionals and staff and people working in the mental health system at the moment? Do people want an approach like this? And what would a good Soteria house look like in the UK? And actually, just to pick up on a couple of things that have been mentioned in the Q&A already, there isn't actually a consensus over exactly what a Soteria approach looks like at the moment. So there are lots of different houses in different countries around the world already. So Switzerland, Germany, Israel, the United States. So there's a whole, there are a range of different countries that have Soteria houses, and actually they do look quite different across houses. So that's something we're also looking at in terms of the literature available, and trying to understand exactly how all of those houses work. So some of them are staffed, just to give you an example, some of them are staffed by people, entirely by people who have their own lived experience of extreme states, like that might be labelled psychosis or other mental health difficulties. And some of the Soteria houses are more kind of led by psychiatry and sort of quite a lot in between. So there's quite a lot of range on how they're working. They've all got this ethos of being a kind of home-like house in the community and being with somebody through those extreme states. But the way that they run is quite different. So the first thing we want to do is try to think about what a good Soteria house could look like in the UK. Second, as well, is to think about, to really understand what might be some of the barriers or challenges, what might be some of the facilitators or things that might help us along the way to actually setting up and sustaining a Soteria house in the UK. So trying to understand how that might fit within the current UK context. So all the other houses have been, the original one, obviously 50 years ago in the United States, in arguably a really different kind of social and political context. The others are in different countries worldwide. Some of them are, some of them have state health systems like ours, others are, privately accessed. So we would want something that's freely available to people. So we need to have a think about how might that link in with the NHS, even if it's not based within the NHS itself. We're also wanting to do a little bit of work in terms of estimating how much it might cost to set up and run a Soteria house in the UK. And doing all of that is a really important thing that we're doing is to really try to listen to a whole diverse range of voices. So we're thinking about who we're inviting to take part in the research. We're wanting people from a whole different range of kind of demographics. So just for an example, the LGBTQ community, people from diverse ethnic communities, people perhaps who have physical disability or who might be neurodivergent, so for example, who have autism, to really think about how we can develop a model for Soteria that feels safe and accessible and meaningful for everybody who would access it. And then finally, the idea is to take that year of work and to use that to apply for another research grant where we would actually be setting something up, hopefully, and then doing some more research to compare it to traditional or typical inpatient admissions in the UK. If we go on to the next slide, please, and I'll hand over to Nick.
Thank you, Kate. So John Reid already did such a good job, a very comprehensive introduction of the kind of evidence that's already out there at the moment for Soteria. But just to mirror that and go into some further detail. So it has been implemented in other countries. So they've been successfully established internationally. For example, there's houses in Switzerland, the US, and Germany, and there's currently none in the UK. And they've all kind of taken a different approach. So how Soteria looks in these different countries varies by country. For instance, some of the Soteria establishments in Germany are actually based on wards rather than physical houses. Yeah, hopefully you can see this lovely picture on the slide here of one of the really big houses that's set up in Switzerland. So it's very diverse in terms of how it's been implicated, which has been part of a reason why we've needed to do this research to kind of look what would a good Soteria house, if a house, look like here in the UK in this setting. Outcomes from existing Soteria houses. So there's reduced readmission. On a 2-year follow-up, people who stayed in a Soteria house were considerably less likely to be readmitted into traditional psychiatric facilities following discharge than people who'd been in the house themselves. And they actually calculated it by number of days from their being discharged since that discharge point that they spent in aftercare or readmissions, and it was a quarter of the days that people in the Soteria house had in hospital care afterwards compared to traditional psychiatric treatment. John greatly pointed out before that there's considerably less medication use. So just over 40% of individuals in the first Soteria house didn't have any medication at all. And those who did typically had much, much lower doses of medication, yet were still able to get the same or if not better results. Another thing that Soteria can be linked to is increased independence. So individuals who were discharged from a Soteria house were twice as likely to be living either with friends or independently, as opposed to people who'd been in traditional inpatient admission, who were considerably more likely to be living with family or to be living in supported accommodation post-discharge, and far more likely to have employment as well. Is it okay if we could change the slide, please? So how exactly are we going to do this? So as Kate mentioned, co-production is really, really important to our methods. We have a great community research team with people with lived experience. And I just want to flag how significant this is. We are actually meeting with them on Thursday. So they are massively integral to our process, and we meet with them often to discuss next steps. In terms of the actual study procedures, so we are currently running focus groups. We've got 3 types of focus groups at the moment. One of them is with people who have lived experience of inpatient admission and extreme states, or who have come close to admission. And that's to explore what a good Soteria house looks like, what people who have had that experience would need to feel safe. We're also doing focus groups with families and carers of people who've been admitted to inpatient and have got extreme states. And that's again to kind of look at their angle, their concerns, what they may feel about the model and how we're able to, reach those concerns, and what they need for them to be supportive. And finally, we are also talking to charity organisations, VCSEs. We're talking to organisations who do something similar to the Soteria approach. So in the UK, there's a few charities who've got crisis houses and things that are similar to the Soteria approach in terms of how they operate. So we want to speak to them about what barriers and facilitators they've experienced. And we also want to speak to organisations that support specific communities that may be minoritized about how we can make sure that this is safe and accessible to everybody. We're also going to do some interviews. So we're speaking to NHS professionals, staff from international Soteria houses, commissioners, policymakers, and other relevant professionals. And that's to get a comprehensive view of exactly what people imagine the issues will be and how we're going to how we're going to tackle them. Obviously, it's been mentioned that some people find Soteria quite radical. So we want to hear out those concerns so that we're able to comprehensively think of solutions and get to that point together. And we've also got a brilliant health economist on board who's collecting the data from international Soteria houses and estimating how much a Soteria house would cost to run in a UK context. Thanks, Eamon.
Thank you.
And I think if we move on to the next slide, unless you wanted to do any questions at this point, Eamon.
What do you guys think? How long we got left, Kate?
2 slides.
Okay.
I could just roll on if you
Yeah,
like.
let's just roll on. It's a nice flow. Loving the presentation. Thank you.
Fab, thank you. So we are, as I said, we're almost halfway through the study. We're very much in the middle of data collection. We're conducting interviews. We've done several focus groups already, with lots more lined up over the next month or so. So very early days to be sharing kind of insights or findings at the moment. And I guess what we were thinking was that this is hopefully the first of several different webinars where we can be sharing our updates on the study and how it's going. And so we'll have some more later on. Watch this space for further findings. But just to share a few early insights from the work so far. I think what's really clear is that neither staff nor people with lived experience are happy with the current system. There's a lot of appetite for change, for something different. What has already come up is, perhaps unsurprisingly, is thinking about how we manage risk. And what's been really clear from both sides, from people with lived experience and staff, is around safety. So for people who've had experience of inpatient stays, obviously people have had some really frightening experiences of being on an inpatient ward and seen things that were scary, and a lot of concern is being raised in our groups in terms of how do we make sure that they're safe places to be, that people feel like it's a calm, peaceful place where they can be working on and working through their experiences. And from the staff side of things, I think somebody mentioned this in one of the Q&As, is that I think staff feel a little bit stuck between this wanting to offer patient choice, wanting to offer as much freedom as possible, but also being within an NHS context which is extremely risk averse. So again, people have raised this concern at the moment, and how we might manage concerns like this. And it's interesting, actually, from some early conversations that we've had with people who've worked in Soteria houses in Europe, is this idea that actually if you're supporting people in an environment that isn't restricting liberty, that isn't creating all of these restrictions for people, that actually perhaps those what they find in those Soteria houses is that the same level of frustration or aggression and violence just doesn't happen because they're not such oppressive environments. So it's sort of thinking about how that might work in the UK, what's going to be acceptable for people from across kind of staff to policymakers to people with lived experience in terms of how that's managed, and whether we can actually persuade as sort of people to kind of take that leap of faith, I think, to try something different and see whether it could be different in the UK too. What's also coming through strongly is the importance of it being like a home-like environment and something that's small scale, that's something that's much more in the community rather than hospital. And I'd say that kind of connection and relationships is coming through as really important. So often when we ask people what are the things that you might want to keep about inpatient from inpatient experiences, it's all around kind of people feeling like actually the relationships they've developed, the conversations that they've had, particularly with other people who are staying on wards, have been the really important bit, the connection and the relationships that they've built over time. So that's been really important. And what's really interesting is how much people are valuing the co-production approach that we're taking. And that it's not just about it just being a research method, but actually that it's really kind of embodying the values of Soteria as well, to develop that together, and for it to be something that's rather than done to by the mental health system, but it's actually doing with and being with people. So that's something that that's a really important ethos of our research as well. Another thing that people have been thinking about as well is a lot of questions have been raised around kind of what happens next. So what happens after somebody leaves a Soteria house, and the ensuring helpful, meaningful aftercare and that continuity, perhaps continuity with people that they've worked with already in the house, so that it's not about parachuting a Soteria house into the system, but it doesn't have those links with the community, those links with really useful mental health support. So we're sort of thinking as well about how might it really thread through and work within the current system too. And if we move on to the next slide, please. Thank you. Oh, Rita, you're doing this one. Your name's at the top.
It's me. I'll fly through this one, guys, because we really would like to get on to answering some of your questions. So the overall aim, as you know, is we want to actually eventually put in a research grant that will compare a Soteria house to the experiences and outcomes for people who have treatment as usual, which is, as we know, inpatient care. So that's where we're heading. As that's happening, we really want to build our community nationally and internationally. And something that Mark put in the chat about how do you influence a medical model. If you live in a country where the healthcare system is very medically orientated, one of the things I think that I would say is about really building your community. And also part of the research is what we're doing this year is getting to know who are the key people that we need to influence, how do we get hold of them, and how do we do it. At the end of December, that will be the end of this particular piece of the research. We'll be gathering, evaluating the information, disseminating, which means send it out to as many people as we can. We'll be using our community research team to look at ways how we can do that as imaginatively as we can. And obviously Soteria Network UK are a network, so obviously we'll be doing what we can there as well. At the end of that, we will actually be looking at what have we got? Have we got enough information to actually put in a grant that we feel confident that we're going to get and we know what we're doing? And we might not. We might think, well, what we need to do is actually gather a little bit more information to fill those gaps. And if that happens, what we'll do is we'll look for further, funding to fill those specific pieces of information, so that when we go for the it's called a program grant, we've actually got everything together, ready to rock. So I think in terms of what's next, Damon, I think we're moving on to questions, and at the end, there are some people who put on the slide as to how you get involved, so that will come at the end as well.
Great, thanks very much. Adam, I can't see the questions. Oh, there I am. Thanks, everybody. I am on speak. Well, thank you all for a fantastic presentation. a very thoughtful process, you know, from impressive data from what works across the international, a quarter people being discharged, a lot less than you know, readmissions, a quarter up in some countries. There's just some really good community evidence out there, and I liked, Kate, some of the sort of scary questions you're approaching about, you know, what does safe look like, and what are those issues? That'd be really useful. But that's just a really thoughtful presentation, and I like the process of all you're doing with all the communities. It's a community-led research project, which just feels really important. I guess we'll go straight on to the question and answers. Guys, can you just dive in a bit? So I haven't been able to look at the Q&A from from my perspective, even with my super glasses. But by all means, if we'll take turns to read out some of the questions that attract your eye.
One of the questions that I picked up on, somebody was asking, will the Soteria houses involve psychologists? Originally, the first Soteria house didn't, and at the moment, the Soteria houses that we know of internationally, that's not how it works. People work alongside peers, or in some houses, trained staff. We're still looking at what the model's going to look like for us in the UK. So there isn't a definitive answer for us yet. But if we're going on what the original model was, it would be more likely that people would access things like psychological approaches when they actually leave the house.
Yeah, it's a bit tricky because there is such a variation in the models. So there was one in the Netherlands, which is unfortunately now closed, but that had a couple of psychologists, and there were some kind of psychological groups available in the house. So yeah, as Rita said, it's quite a range. So I guess a lot of these questions are really, really helpful questions for us as well, because they're all the types of questions that we're wanting to ask as part of the research. Is what would people want, and how do we answer some of these? And I imagine we won't have all of the answers by the end of the year, but we hope to have as many as possible, or at least know where our gaps are.
I'll throw this question out because it's been put in the chat, but whether I'll be able to answer it, I doubt it. But is there the political will for Soteria houses in the UK? This is a personal answer. I think that there is an appetite from the top, right down to people like me who lose their services, for change and wanting something different. I genuinely believe that. I think the fact that the World Health Organization has published about it, then we can't deny it. We have got the people like Geronimo and Creef and what have you, who are banging on the doors, giving some very strong evidence, research evidence that we need something different. So I genuinely believe that people know we need to do it. We need to change. I think the stumbling block is people don't know what to do. And I think that's what I genuinely believe. And I think that that's where Soteria is actually bridging a gap and starting to move in a different direction. Because my genuine belief, I've sat on boards for reviewing applications for an HR, and there is a absolute genuine push for patient and public involvement. But this is my personal view. I think if we'd applied for this grant 6-7 years ago, I don't think we'd have got it. I think because it's radical, it's different, it's an experiential thing, it's not scientific. That's hard to research. It's not impossible, we're doing it. But that is my answer to that question. Is whether we've got a definite political drive, not sure, but I think it's been forced.
Yeah. Thanks, Rita. I think it might also be worth adding that if we can show that not only are the outcomes better than the usual treatment, they could actually end up being considerably cheaper. Good. And that might be something that could persuade some governments to try it out. Perhaps that's a controversial thing to say, but money talks, doesn't it?
Do you know
certainly
what,
in the long
Jen,
term.
I don't think it's a bad thing for people to expect value for money.
Yes.
I
Sorry,
really
what did you
don't.
say? Yeah.
I think the fact that Soteria, my belief is Soteria will be cheaper.
Yes.
Great. Good value for
So I
money.
think, yes, I think
Great.
John was trying to say something. Yeah. Sorry.
Well, I was just agreeing, really. I mean, certainly if you can show that it works, and we know that inpatient hospitalisation does not work. I mean, the evidence is absolutely clear on that. We can show it works. That automatically then saves millions of pounds, because currently we just turn people into long-term career sort of mental patients. Everybody knows that, and I think the climate is changing. It's endless mental health crises in the newspapers and television. Every 3 months there's another inpatient unit exposed as a completely violent, horrible place to be. And there's also a new cross-party parliamentary group established in the last few weeks called Beyond Pills, which is focused more on antidepressants than the psychosis field, but they would also be sympathetic to this sort of thing. So there are people in powerful places, including the World Health Organization and the United Nations, calling for exactly what you folk are trying to do.
I think also, in a sense, this does feel, I mean, there's so many bad things happening in the wards. There's so many inquiries, in Norfolk, Edenbridge, Essex. There's sort of so many unexplained sort of deaths and things happened on wards or 6 months after discharge. Mental health services regarding people in crisis are broken. It's quite a lot to see, to dip down underneath it all. And there's clearly an appetite for something kinder and more innovative. These are small sort of places, and some of the houses I met in, people in Soteria, Vermont, they have a confidence how to handle crisis, the self-harm, the suicidality. They have these sort of internal training and confidence how to help people in crisis, which I haven't really seen much in some of the inpatient care wards. So I think it's just a real people, and our kids, our families and friends deserve better, and we should help, Sorry, that's just for me pitching my bit.
I just wanted to pick up on a comment that we've had in the chat. I'm just looking for it because it's jumped away from me. But in answer to the question around psychologists, Brenda had added a point. So Brenda, you must be from the New Mexico Soteria. Thank you so much for joining. So Brenda said that, I'm trying to find the comment. I wish we could beam you in, Brenda. She said that they must have a psychologist in the New Mexico one. So she says, we must have a contracted psychologist. The rest of the team will be certified peer specialists with a director as well. That's fantastic. So really exciting. Congratulations. New Mexico Soteria is on its way. They've just got their funding. So an insight from there. We'll have to have you on a future webinar.
Somebody was asking about size. I can quickly answer at least what the original size was. Moshe was quite clear. No bigger than 10, including staff. That might be too small for here. I'm not saying that's the answer here. I'm just saying that was the original model, which you lot will know, but some people listening might not know. So beyond 10, it starts getting into not an institution, but more impersonal and more unnatural, because very few ordinary houses have more than 10 people in Britain anyway. Sorry.
From what I know of the other houses as well, I think that's quite consistent with the existing houses. So less than 10 is.
Yeah, well, then economics comes in. If it gets too small, it becomes economically unviable, doesn't it? So it's a balancing act. Yeah.
But there's one here from an RMN in Salford wanting to know if we would be interested in doing some training. I don't know whether that's something that might come out of the research, or is it something you've thought of?
Potentially. I mean, we're certainly do get in touch with us. Really, really happy to come and have a chat with you, and certainly share what we're doing and with your team. And yeah, training perhaps once we've got some answers ourselves, but we can certainly yeah, point you in the right direction and have a chat with the team about what the Soteria model looks like and so on. So yeah, please do get in touch. I've put various links just for everybody, because I know we're coming up to 8. Put various links in the chat, so and we can send these out as well. So links to our study page within our NHS Trust, and our generic email address if you'd like to join our mailing list, and then mine, Rita and Nick's email addresses as well. So do feel free to get in touch and ask questions, share your thoughts, get involved.
Yeah, and we hope to be doing more of these in the future, but we can't yet say when. We need to get a bit further on with the research, but it's just brilliant that so many of you have come, and I'm sorry we haven't had a chance to answer all of the questions, but we'll try and follow that up. How are we going to save the questions? Are we managing to do that?
Yeah, we are.
Yeah.
And we're going to answer them in a blog, Jen. So
yes.
So obviously you can put it on the Soteria UK website, and we'll link it to the Manchester one as well. So we'll be answering all the questions via a blog. So thanks for your efforts. It's not been wasted. We really appreciate them.
Yeah, we'll keep up as many as we can. We've got Nick has been working hard on setting us up a blog on the Medium blogging website. This is a bit beyond my technical knowledge, but we've got a few posts that are ready to go. So we'll be, if you join our mailing list, we'll be sending those out and sharing. We can share those with the Soteria Network as well. Links to the blog. The plan is to do a post to answer some more questions from this chat as well.
Just to add, a couple of people have mentioned that in the chat it's hard to copy and paste the links. So if you are having problems, we all have access to that Soteria inbox. So that's, I should have got this up before I started. That is the Soteria Research Study at gmmh.nhs.uk. So if you just wanted to take one email, we all have access to that. So anything that you sent in there, we'd be able to dish it out to who'd be most appropriate to respond.
Tell you what we could do is put up the last slide. That's got a few of our contact details if you want to take a picture of it, take a screenshot.
Adam, could you just put for some reason I can't, could you just copy my last text in the panelist, just to say everybody keep in contact with
I have.
Oh, great, thank you.
Yeah.
There's so many questions in here answer. I mean, I'm going to probably wrap up now, just to thank. We are going to sort of scoop up all the questions, and I'm very interested in the training research. I want to sort of do some training and learning how to run events and houses in London. So I'm sort of be doing stuff in London. Hope we build up a little clique. But thank you. I think we'll wrap up now, everybody. Just big thank you to all the panelists for all your research, and to keep in contact with, we've got all the emails there. We'll be sending up doing some follow-up blogs on the Manchester research site, and also linked to our own UK network site. So please keep in contact. We'll be doing some more research updates, either in this form or any other forms, on blogs and etc. It's a really exciting piece of research. I think it's much needed, and I think it's going to make an impact. Really give the credibility for much needed alternative to inpatient care.
Thank you. Can I say big thank you to Adam and to Eamon for putting it all together, as well as the speakers. Thank you. And for all the work you've done behind the scenes, Eamon. Brilliant.
Okay, everybody. Just going to wave goodbye, I guess. I don't know what you do.
Thank you all for coming.
Bye, everyone. Bye-bye.
Bye-bye,
Thanks,
everybody.
everybody.
Bye.
Bye.
Bye.